Hi, my name is Dr. Terry Ng. I'm a medical oncologist from Ottawa, Canada. I'd like to present and summarize the background and the results and conclusions of REaCT-HOLD BMA, which was an investigator-initiated randomized controlled trial seeking to evaluate how we should be using bone-modifying agents in the longer term after more than 2 years of prior treatment in patients who developed bone metastases from breast cancer or castration-resistant prostate cancer. So this was, as I said, a randomized controlled trial, open label, and it was multi-center. This was a non-inferiority study because we are looking to show that giving bone-modifying agents less frequently led to similar outcomes for patients compared to continuing the same frequency of treatment. Importantly, we used 2 patient-reported outcomes for our primary endpoint. They were physical functioning subscale from the EORTC Quality of Life C30 questionnaire and the functional interference subscale from the EORTC Quality of Life bone metastases module questionnaire. These outcomes were evaluated at baseline and then every 12 weeks until 48 weeks post-randomization. And patients in this randomization were stratified by their cancer types, so whether they had breast or prostate cancer, prior bone-modifying agent frequency every 4 or every 12 weeks, and whether or not they had prior symptomatic skeletal events, which is a risk factor for future symptomatic skeletal events. So participants either continue the same frequency of treatment at the time of randomization, or they started receiving these bone agents every 24 weeks. In order to recommend de-escalation of bone-modifying agents, both the physical functioning subscale and the functional interference subscale needed to meet its non-inferiority endpoint. We use pre-specified non-inferiority margins based on published minimal clinically important differences. We needed 240 participants to have 80% power with a single side alpha of 0.0125, and that's after accounting for attrition and mortality. And so we also used repeated measures ANOVA to adjust for strata and cancer centers, and this was pre-specified in the protocol. And so essentially the main finding from our study was that both the physical functioning subscale and the functional interference outcomes in the de-escalated arm was non-inferior compared to standard frequency treatment. Furthermore, in terms of key secondary outcome analysis, we looked at rates of at least having 1 SSE. That was 21.9% in both arms. The distribution of the number of SSEs, being at 0, 1, 2, 3, or 4, was no significant difference between the 2 arms. Skeletal morbidity rate and 2-year SSE-free survival were also not statistically significant. BMA-associated toxicity like renal impairment, symptomatic hypocalcemia, and osteonecrosis of the jaw were low in incidence, less than 3% across the board, and not statistically significant. Bone metastases-related hospitalizations were also not statistically significant, not statistically significantly different. And so in summary, the administration of bone-modifying agents every 24 weeks was non-inferior in terms of physical functioning and functional interference compared to standard frequency treatment. This was the first randomized controlled trial providing level 1 evidence that we know of informing the usage of bone-modifying agents beyond 2 years of treatment.